Good afternoon. Hello and welcome to the Urban Institute. I'm Rekha Balu. I am VP of our Office of Race and Equity Research, and I also happen to be Director of Federal Equity Initiatives, which means I get to work with a lot of federal agencies and organizations like yours that work with federal agencies. And as a result, I have gotten to hear a lot about the priorities that this current administration has set for rural populations and improving their outcomes, particularly health outcomes. So was delighted to hear that this event was happening and to be some small part of it. So before we begin, just go through the usual logistics for this hybrid event. So we're broadcasting and recording this event, and the recording slides and all the related materials will be shared with folks afterward. And for our online audience, we have live captions for this event. And so if you just go to the bottom right corner of your media player and click the CC button, those captions should show up. And of course, we want both our in-person audience and our online audience to be engaging in questions and dialogue. So you can online put your questions in the Q&A box at any time. And for those in person, there's a QR code at your table, and you can scan that, and that will give you a place for you to enter your questions. And via that QR code, folks in person can also see the speaker bios for this amazing set of panels that we have today. And for anybody who wants to be part of the conversation, you please use our hashtag #LiveAtUrban. And of course, we'd love your feedback after the event. So when you get the email from us with the post-event survey, please take a couple of minutes to share your feedback. And it will shape a lot of what we end up doing in the future. So know that it is read and considered. So it's great to be here today to talk about rural health equity through partnerships, data, and finance. And that's because at the Urban Institute, we aim to deliver evidence-based solutions and actionable policy recommendations. And I think particularly from my perspective, to address structural inequities, things that have been in place through a combination of systems and structures, things that are largely sometimes out of an individual's control, like the geography that they happen to be born in, and things that are a confluence of events like health status. And of course, we all here know, that's why we're here today, that if urban areas thrive, but rural areas don't, we have certainly failed to explore and elevate the complete or right set of solutions. And so that's why we're here today, to talk about what those solutions might be. And we all know that many communities across the US are currently struggling to access health services, and that those communities experience worse health outcomes than those with better access. And rural places face unique structural challenges that limit their access to health services, in addition to the distance and limited transportation options that I'm sure many of you have been talking about over the course of your careers, seeing unreliable internet, hospital closures, limited choice in healthcare, and how they all compound for each other. And in addition, rural communities are often lacking some of the basics that many of us in urban areas can sometimes take for granted: affordable, quality housing, safe drinking water, and well-paying career opportunities. And some rural regions and communities have been systematically denied these investments via structurally racist systems and practices that allowed poverty to persist. So if we think of areas in the Black Belt, in Appalachia, in tribal lands, in immigrant and refugee communities, poverty, health, and overall quality of life outcomes tend to reflect this vicious cycle of systemic disinvestment and limited opportunities for change. Fortunately, there's plenty of innovation to point to and ideas for how we address some of these systemic barriers. And so we're joined today by thought leaders and practitioners who devote their time to developing and implementing promising models with the goal of improving health services and access for rural people and communities. And they're doing this by examining rural needs, tailoring solutions to the diverse rural cultures and contexts, and tracking progress on health equity goals to ensure that the solutions are working. So I'm excited to hear about those solutions today. We hope you are going to walk away with inspiration to try some of these new approaches, find willing partners here in the room and online, leverage data, and explore opportunities to really invest in rural health in new ways. So as I noted before, we really want today's event to be interactive, so please post questions via the QR code or online. And now it's my pleasure to turn to our co-host for this event, to Urban's co-host for this event, Partners for Rural Transformation. Elaine Crutchfield from Communities Unlimited and her colleagues have been really critical partners to our research team on a number of different projects that elevate rural health, water and sewer infrastructure, and economic development needs. And she really focuses on how to maximize the impact of those rural-focused investments. So we're very pleased she is joining us to help frame our discussion today. Welcome, Elaine.
Can everyone hear me? Okay. Thank you very much. I am very excited to be here today with joining you as we learn what is working well to meet the needs in rural communities to address healthcare and what is still needed to support those needs. I have the pleasure of being up here making this welcome on the behalf of Partners for Rural Transformation as the chair of the research work group. The research work group is comprised of members from all of our partner organizations and has invested with Urban Institute and others to really explore opportunities and to bring together a collection of information in a guidebook and at this convening today, which we hope will help spur innovation, further discussion, and ultimately result in more healthcare resources that meet local, unique needs in underserved communities. Briefly, the Partners was originally created by a collection of CDFIs that are working together to raise the voice, raise the shared experience, the data, and the information from folks that have been living in persistent poverty counties for generations. Persistent poverty counties, those that have been there for multiple decades, represent some of the types of communities that we tend to hear about, labels that get applied like Appalachia or the Mississippi River Delta or tribal communities or Native American communities. These are places where Americans live and work. They want to have the opportunity for a livelihood in their hometowns that creates healthy lives for them. And the rural healthcare equity issue is one obviously we all care a great deal about. So that's who I am. Of the partners in Partners for Rural Transformation, I'm from Communities Unlimited. We're one of those Southern organizations. Some folks have asked, where are you from? Based on my accent, I don't think I have an accent, but I've learned that perhaps I need to reconsider that. Communities Unlimited is one of the CDFIs that works across Oklahoma, Arkansas, Tennessee, Texas, Louisiana, Mississippi, and Alabama. In our area of the country, we have about 45% of the persistent poverty counties. I have personally been out in community and listened to residents share their concerns, talk about the opportunities in their communities, that, this lack of a good livelihood or lack of infrastructure or lack of access to health care is all that's holding them back. We have so much going for us. They say, if we could just solve this. So again, I'm just so excited to see folks interested in learning about how we pull together and collaborate to accomplish that. I mentioned a guidebook, which I will leave more detail to be shared at a later time. But the resources shared here today, this convening, the guidebook that was done in partnership with Urban, all was supported with funding from the Robert Wood Johnson Foundation. And without it, we wouldn't have been able to bring this and share this with you today. Katrina Badger is our program officer. She's serving as a moderator today, and she has been of invaluable support directly to the research work group and staff and various other partners at PRT. So we do appreciate that. With that, please do participate, enter your comments and questions. And then I would like to introduce our next speaker, Mr. Tom Morris is the Associate Administrator for Rural Health Policy with the Health Resources and Services Administration. And I read that to make certain I got it correct. He has a lot to share, a lot of experience. He oversees funding that makes significant impacts in rural communities and is going to set the stage for us today with the conversation by giving us sort of a general overview of the state of rural health. Thank you.
All right. Well, good afternoon, everyone. All right. I can almost hear the people out listening remotely. Anyway, really appreciate the opportunity to join you today and to talk about this issue. I really want to just give a nod to the way you framed this meeting, the fact that you're talking not only about the challenges, but also about, so the solutions and ways forward. We can often get bogged down in the negatives that happen in rural America and the challenges they have, and those are all worth quantifying and knowing about. But at the same time, there's also a lot of really creative things going on out there, and so I like a meeting when we can do both, and that's certainly this. And it's an interesting time for rural health, and that there's probably more interest in it now than any time I can remember. And I've been doing this, for quite a while. And so there's interest in the administration, there's interest by the Congress, there's a lot of stakeholder organizations that are really getting engaged. And so that's really great. And I think what I also appreciate you all doing is adding that health equity lens. That's really important because just about every rural health issue we could talk about has a health equity angle to it. But sometimes they're framed solely as rural health issues, when there's also this deeper sort of health equity dynamic at work. And so we'll talk a little bit about that as we move forward. Okay, so you can't start a rural presentation without getting into an argument about how you define rural. We could spend the whole afternoon on that, we won't. But it is worth starting with it just to set a context, because the challenge with this, of course, is that there's no perfect way to do it. So what we find is that the Office of Management and Budget defines rural by the county level, and the Census Bureau does it at the census tract level. And the problem with those two building blocks is they're not uniform around the country. As you go west, the counties and the census tracts get larger and larger and larger. And so what we've done in the Federal Office of Rural Health Policy is we use a hybrid of those, where we certainly identify as rural all the non-metro counties, but then we have methodologies that will allow us to reach into each of the metro counties and pull out the rural census tracts. What it results in is basically 19% of the population being defined as rural, and that spreads across 80% of the landmass. But geography only gets you so far when you're talking about rural. I mean, there's so many other factors, and I think they were referenced earlier, but there are physical barriers. There's whether you live in a mountainous area, do you live on an island? Some people are really affected by weather in terms of access to care, and you have to think about all those. And then we talked earlier about the persistent poverty counties. You think about using indicators such as the Social Vulnerability Index. All those things need to be taken into account when we're talking about rural. And then there's all the things in terms of infrastructure, what's there and what's not there. Are there hospitals, are there clinics, are there clinicians? All those things are worth considering when we think about defining rural. And the other interesting dynamic, I guess, getting back to our health equity angle, is who lives there and how is it changing? And back in 2021, the Brookings Institute did a really nice report that looked at the changing diversity of rural America. And I thought it was an important milestone, because I think often there's this stereotypical version of rural America that it's largely older and whiter, and that's true in some areas, but it's not true everywhere. And so the Brookings report, I think, was really important, because what it basically showed was 1 in 5 rural Americans was a member of a racial or ethnic minority group. And it's changing. When I first came to government, it didn't look like this, and it does now. And the Center on Rural Innovation did a nice study last year that sort of looked at what are the regional patterns. And the reason I bring all this up is because if we're thinking about policy and program development, if we don't take into account the changing dynamics of the rural population, we're going to have the wrong interventions. And so I think it's important to take these things into account on the front end. And I'm glad to see that research out there and doing it. We also got to sort of set a context for the rural health landscape. And many of these are things so I'm probably preaching to the choir to a lot of you and bringing any of this up. But there are sort of some certain things that that we talk about all the time. We know that maternal mortality is higher in rural communities, and it's higher for women of color in rural communities. We know there are higher risk factors, whether it's smoking or substance use or a number of obesity is a factor. All those things have to be taken into account. We've got tremendous gaps in terms of access to behavioral health. We've got longstanding challenges in terms of the workforce, and the distance to care, especially for specialty care, can be considerable. And then we haven't even brought into the discussion yet emergency medical services, access to, say, an ambulance. We have new research at the University of Southern Maine that's quantified all the EMS deserts around the country, and it's dramatic. The number of people who are at least 30 minutes or 30 miles from where their ambulance is located and what that means in terms of access to care. The uninsured gap, while narrowing, is still there for rural areas. It's gotten better, I think, because there are more plan offerings to the marketplace. We've seen more states take advantage of some of the expansions in Medicaid, certainly during the pandemic. But, I think that's still a gap there that we have to take into account. And not even included in this list is what the challenges are for people, Native American people, and for veterans. We know that veterans tend to volunteer for the armed forces at a higher rate than their urban comparison group. And so where do they go get their health care when they return home? And it's not just, and for tribal, it's not just the people living on tribal lands, but there are people who are not living on tribal lands, but still are enrolled members of their tribe, and where do they get health care as well? And so if you don't think about all of those factors when we're thinking about what the interventions might be, we may come up with sort of a square peg in a round hole. So we referenced rural hospitals earlier, and I think it's important to set a context for the full sort of rural health care infrastructure. And I use the term here patchwork because I think safety net's too strong a term. That would imply that it's a net and it captures things, and it really doesn't. We know there are significant gaps out there. The one common link, I think, if you look at all the clinics, primary care clinics and rural hospitals across the country, is just about all of them have some sort of special federal designation. Federally qualified health centers, Medicare certified rural health clinics, critical access hospitals, Medicare dependent hospitals, sole community hospitals. It's a real alphabet soup of provider types. But they're there because I think Congress and the administrations over the years have realized that there are unique circumstances. The term structural was used earlier. And so we really sort of, a lot of the healthcare infrastructure in rural America is made up of these special provider types. So this map in particular shows where the 1,300 critical access hospitals are. There in the pink. The green are the rural health clinics, and then there are about 5,000 rural health clinics. 40% of community health centers are located, their access points are located in rural communities. And I could do a whole separate map just where all the tribal clinics, the tribal hospitals, and the veteran outpatient clinics are. The point being is there's a big federal investment in terms of access to care, and yet we know there are still gaps. And it's interesting as you think about rural health policy over the years, it's been heavily focused on the finance side of things, almost finance as a proxy for access. And that's good. I mean, we wouldn't have this infrastructure if it wasn't for the bills that have been passed over the year to make sure that people can get enough reimbursement to be economically viable. But think back to the other slide where we're talking about some of the gaps in care. A lot of those are public and community health issues and disparities. And we don't see as much focus there. We tend to rely on state and block grants to go to both rural and urban communities to address a lot of those disparity issues. And so that's a bit of a challenge because do they get past the higher population areas? And I think the record is somewhat mixed there. One of the metrics that's really sort of been intriguing for us for the last handful of years is looking at some of the CDC work around the 5 leading causes of death and the higher rates in rural communities of racial and ethnic, the higher rate of excess or avoidable death. And so Macarena Garcia at the CDC and Diane Hall presented last year at the National Rural Health Association meeting with new data that will be coming out in an upcoming MMWR. And basically it mirrors what they found in 2017, 2019. We've got gaps here and they're getting bigger. And so it's a real challenge. There's also some research maybe about 4 years ago by Georgetown and the University of North Carolina that looked at why is mortality higher in rural areas. They found the drivers are the same. They're just more determinate in rural communities. And so these get back to that structural consideration. What's going on in these communities that really drives this and what can be done to address it? The opioid crisis is another good example. It's hitting both rural and urban communities. But I would think that it plays out a little differently in rural communities because of the lack of treatment infrastructure and the lack of providers to provide the services needed for folks suffering from substance use overdose disorder. And so there's also stigma and geographic isolations. All of these really are important considerations. And that's why co-location of behavioral health services and primary care is so really important. And what we're seeing in the data this year, if you look from 2020 to 2021, yes, the urban rates are still higher, but they're growing faster in rural communities, 67.6% in rural compared to a 54% increase in urban. And so this is a significant challenge in terms of what we're doing in rural communities. Now, I mentioned earlier that we tend to rely on state and block grants often to address public health issues. This is an issue where we're trying something different. We still have a lot of funding going down through CDC and through SAMHSA, and that's a really important part of the overall strategy. But the Congress and the administration have also been supportive of targeted rural funding. So we have a program in our office, the Rural Community Opioids Response Program, that funds consortiums in rural communities to get at prevention, treatment, and recovery. And so the combination, I think, of relying on the state trickle-down dollars and then injecting directly into rural communities to do capacity, I think offers perhaps a path forward on some of these more intractable public health issues that we're talking about. Workforce is one of those things, if I came 20 years ago, we'd be talking about workforce, and if I come 20 years from now, and I won't, but if I came 20 years from now, we'd be talking about workforce. And unfortunately, these numbers are fairly consistent. 60% of the health professional shortage areas in this country are in rural communities. We have significant gaps, more than 300 rural counties that have no behavioral health clinician at all. But there are some positives here. Last year, the Congress changed policy in Medicare, so now marriage and family therapists and licensed professional counselors can get reimbursed starting January 1st. And the reason I mention this is because these are folks that get through the pipeline a little bit faster. I think they're more likely to get recruited to rural communities. And so I think those sort of policies make a lot of sense in sort of moving forward. One of the challenges we have is how many folks are ready to bill for those, help them figure out how best to utilize those providers, especially as we talk about integration of services. And there are also programs like the National Service Corps that I think play a really important role in terms of supporting clinicians to go into rural and underserved communities. We talked about rural hospital closure, and that's certainly a big issue that my office focuses on. We're right at now at 150 closures. It says 156. One of the things that's happening is we have a new provider type out there called the Rural Emergency Hospital, which Congress created. It's basically saying, if you're a struggling rural hospital, if you give up your inpatient beds, we'll give you an extra grant to address community health concerns. And so far, we've had 15 REHs approved. And so the reason this is important is because before, if your rural hospital was failing, you basically had two options. You either were with a hospital or you were not. You were either a clinic or a hospital, and there was no in between. And so as we think about policy solutions, the REH, while not a solution to the rural hospital crisis, is at least giving communities more of an option to preserve access to emergency services and outpatient care. And so we're happy to be able to provide some technical assistance as communities sort of work towards that. The other challenge I think that rural hospitals have, a variety of reasons why they're not doing well, and many of them are structural. They're heavily dependent on Medicare and Medicaid. They tend to have very low patient volume, so you got high fixed costs, low patient volumes. It's not a recipe for success. And so one of the challenges we have is what would be the solutions to that. So in the President's budget this year, we had two proposals, because I think we've seen over the years through some of our efforts that if you can get the right intervention, if you can grow service lines a little bit in rural communities and their rural hospitals, you can get enough revenue in there to move them from being financially at risk to being economically viable. So there are $30 million in proposals in this year's President budget for 2024 that would get at exactly that. For example, we have a program we started to give money to expand into chronic obstructive pulmonary disease, and that's worked really well as well. OB is a real concern as well. Only about 56% of the counties in this country have access to a hospital with OB, so that's a real concern, something we ought to take into account. And then I would make a quick nod towards the need for more research that focuses on health equity. Too often we stop at rural-urban and we don't look at sub-rural, and we don't look at racial and ethnic impacts in that research. So our research center at the University of South Carolina, I think, does a nice job of sort of pioneering approach to look at minoritized communities and a variety of health issues that affect them. And we'd like to see more folks sort of follow that. And then just to talk about some of the successes out there, one of the things we're lucky with is we have some grant programs that basically fund networks. We don't fund a single provider, we fund a consortium of folks. So this example here is from Arkansas. They've been able to do work around rural hospitals, quality, workforce, as well as behavioral health, because they bring together a network of folks who have a commitment to do that. And they've leveraged our grants time and again. We have a similar project going on in Michigan that's looking at it from the opioid crisis. And you're going to hear from a speaker from Mariposa Community Health Center, which has done a great job of leveraging our dollars over the years. And so I guess the thing I leave you with is that the partnership angle really is the important one. If we can get folks to work together, I think we have a chance to make this work. It's when we operate singularly in silos that I think it doesn't work as well. So thank you for the chance to talk a little bit about these issues today. I appreciate the opportunity. I'm looking forward to the discussions.
Good afternoon, and thank you to Partners for Rural Transformation and to Urban Institute for co-hosting this event. This panel is here to talk really about the importance of community rural development and finance in driving health equity outcomes in the long term. Really thinking about the ways that finance can shape community conditions, regional conditions, that create or separate for people from opportunity. I am Katrina Badger. I'm a program officer at the Robert Wood Johnson Foundation and have had the privilege to work with the Partners for Rural Transformation and with Aspen CSG for quite a while. And I think I'm going to actually ask the panelists to just quickly introduce yourselves, your name, organization, and just really quickly what brings you into this conversation.
Yeah, so my name is Emily Burleson. I'm with the Partners for Rural Transformation, and I am the Policy and Research Project Manager there. What brings me here is the populations and communities that we serve. While we are not specifically health care workers, we do work that impacts health, and so that is an important part of our work.
Hello, everyone. I'm Alex Lawson. I'm the Senior Vice President for Strategic Initiatives at HOPE. We are a CDFI based in the Deep South states of Alabama, Arkansas, Louisiana, Mississippi, and Tennessee. And we primarily work in communities of color. 1/3 of those are rural, which is facing a healthcare crisis. And we work to bring our financing tools to either revitalize or bring in new health centers and hospitals to those areas.
And I'm Bonita Robertson Hardy. I'm co-executive director of Aspen Community Strategies Group. What brings me to this conversation is at Aspen CSG, we really think about what will it take to do economic development differently, and particularly in rural communities. What does that look like? We've been doing this work for over 30 years, and so and health is an integral part to that.
Thank you all. So I wanted to start by grounding the conversation, our particular conversation, in a slightly different frame around what we're thinking about when we think about rural than what Tom provided. And I'll lift up a recent book that Catherine Eden and Luke Schaefer just published called The Injustice of Place. If you haven't seen it, I would encourage you to read it. I found it tremendously useful. They looked at the intersection of the worst health outcomes, worst economic outcomes, and worst mobility outcomes in the country across rural, urban, all geographies. And not surprisingly, they found that most of those places with the worst intersection of outcomes are rural places, for the most part. And that the most of those places are predominantly people of color, Black communities, Indigenous communities, Latino communities. And although at the face of it, on the surface level, those communities might look dramatically different because they combined the qualitative and quantitative research with deep historical research, they found that, again, not surprisingly for those that are living and working in those places, that there is deep similarity in shared histories around intensive resource extraction, dramatic human exploitation, and around single industry that really advantages a small group of elite and disadvantages the rest of the population in those places, and that makes those places particularly vulnerable economically due to automation and global competition. And they have kind of taken hold to what has been, I think, a long-term terminology in really recognizing these regions as internal colonies. So that's kind of the type of places that we're really thinking about and that PRT is really working in, that Aspen CSG is really trying to advance solutions and support in. So given, I think, the importance that that book contributes to the research landscape and the gap in evidence that has been out, but that it's not new knowledge for those living and working in these places, that's, I think, the richness of the conversation these panelists can bring us today. So the first question I wanted to tee up for the three of you is if you could just lift up in your work, in those places, those types of places, how do you see the intersection, the importance of addressing structural racism, other structural forms of discrimination, and how that leads to health equity in the long term?
So I would say at Aspen CSG, we think of it as critical and integral to the work that we do, right? So Community Strategies Group recently, after working with practitioners and policymakers and researchers across the country, we released what we call the Thrive Rural Framework for Equitable Rural Prosperity. And this framework at the core thinks about what will it take for rural communities to get to this ultimate outcome. And this ultimate outcome wasn't decided by CSG. It was really decided by working with a working group and a theory of change working group and a group of practitioners to come together and say, what does it take? You all are out here doing the work. What will it take? And the ultimate outcome really focuses on what will it take for communities and Native nations across the rural United States to be healthy places where each and every person can belong, live with dignity, and thrive. And each of those words is very intentional. And to get to that ultimate outcome, we have to look both at the systems level and really look at that local level. And then foundational to that is making sure that you're dismantling what we think of as racism, placism, and classism. And those in rural places particularly have particular intersections, which I know all of my colleagues up here can talk about. And we can't get to this ultimate outcome where every place is healthy, where people feel like they can belong and live with dignity and they can actually be thriving without getting to the root of some of this racism, placism, and classism. And that's in every community. And so what we try to do at CSG is really lift up the practitioners that are on the ground doing this work and really having these conversations, thinking about how you're translating these conversations in different places. Because what might work in the Black Belt, I'm from New Orleans, so what might work in Louisiana and Southeast Louisiana might not be the true for what's might not be true for what might work in Appalachia, right? And so you have to know that and know your community and work with folks that know the community and have trust within that community. But central to our work is really uplifting the voices of people that are from and within community that are working at this intersection of racism, placism, and classism. Because in every community, it might not be that there's a divide among racial lines, but what you can see is that there are class divides. And that might be what brings people into that conversation to start actually thinking about what can they do within their community to make a change.
For me, data has helped give me language for what I have always experienced and witnessed in our communities. I personally come from a census tract in Mississippi that for Black boys who look like me, who came from low-income households like mine, has an economic mobility rate of 1.4%. To put it starkly, for folks of that demographic who stay, there's a nearly 99% chance you won't achieve the American dream of climbing the economic ladder. And if you put all of those such census tracts on a map, it looks nearly identical to maps that show all the health disparities that we're talking about today, the other persistent poverty counties. It also looks nearly identical to a map of the concentration of enslaved Africans at the beginning of the Civil War. Things have not changed for hundreds of years, and that is systemic, that is structural things that we have to change. And also, the lack of access to healthcare often comes with the lack of access to quality housing and healthy food and having good air quality and all of the things that come with that. So clearly there's a strong need, and all of these things are connected. And that's why it's no surprise that our communities that we're talking about lead the nation in death due to heart disease and diabetes and cancer and all of these other really big things. And on top of all of that, there's a policy environment that does not support change there. Out of the 5 states that we serve, 3 of them still have not expanded access to Medicaid, which is undeniably would help solve some of these issues related to these closing hospitals. But if the need itself weren't enough, as a community development finance practitioner, I also just have to note that when we make loans to hospitals, they perform. We have yet to have a healthcare loan go bad, 0% delinquency rate. So there's clearly a case to be made that community development finance and public policy can be fundamental drivers of creating some solutions to these fundamental structural racism issues.
Great. So I want to start by saying persistent poverty is not accidental, as you have just heard. Intentional policies and decisions were made to purposely exclude these regions from economic mobility, and it excludes people by place and race, and that's intrinsic in the work that PRT does. One way that we try to leverage the work that we do and to continue to do more of it is to get some work done to have data and stories and humanizing that success in a way that we can talk with other people and, like you said, have stark examples of what that data is saying. CDFI is serving these regions of increased persistent poverty. Counties really need flexible funding to get that work done and to be able to tell those stories. And taking a step back, for those who aren't familiar, Persistent Poverty County is a county that is 20% of its population is below the poverty line for at least 30 years, so it could be 30 years or more. The CDFIs, like PRT partners who serve regions of persistent poverty, often rely on super complex capital stacking, and this is typically considered the norm to get projects done, especially with larger community and facility projects. With CDFIs not having access to the adequate liquidity due to their non-conforming nature of financing, CDFIs serving these regions are forced to pull funding from several different sources. While all of these sources of funding are extremely welcome, they can sometimes come with additional requirements that makes it harder for a community that's still bolstering their capacity to get these projects done a little bit harder. And so flexible funding in these communities is absolutely necessary to push these projects over the finish line and not further marginalize these communities that are typically communities of color, Native and/or rural. Flexible funding would allow these communities to get this job done and address these health disparities in these areas and start to have the work and the words to say that we're doing this work and it's good and we need funding to continue doing it. Taking it a step further, federal funds are typically not available from the start for smaller communities that are persistently poor, rural, and Native, because smaller communities that often go through the rigorous and time-consuming application process for federal funding end up getting hit with a barrier of matching funds, and flexible funding would address that so that this wouldn't be a non-starter anymore. And even if it was to ease or completely waive that match fund, we could get more projects done in these communities. And we really want to be able to have the data and the evaluations and the stories of the people we're serving, because we want to be able to have people bet on us and bet on our projects and serve with us on these projects. And I know PRT and our partners and national partners would always welcome folks to join us in this fight.
Awesome. So to dig into those data and stories, what we're all really here for is to hear about specific examples of success around financing for health equity.
I'll start. So we, a few years ago at Hope, did a capital needs assessment and realized that a lot of these rural health centers and hospitals actually had the ability to take on debt in a much greater sense than they thought they could, and use that as a tool to improve or to establish new centers. So there's one in particular that I'm reminded of. It's called Jefferson County Comprehensive Health Center. And it's based in this small town, Fayette, Mississippi, about 1,400 or so people, 99% Black population. And we made a loan to them of just $500,000. That's what they needed to bridge that capital stack that they had already been working so hard to put together. And not just the healthcare practitioners, but everyone in that community really came together to make that happen. And we finally were able to do so. We heard a resident say that not only is this providing the healthcare that we need, but this is the first new building we've seen in this community in 35 years. So it's having a huge economic impact there too. It created 70 new jobs for all local people. They now serve 9,000 patients per year, and they're providing very important quality primary care, mental health care, and HIV screening, and it's all the things that this community was lacking because the nearest health center before that was 30 miles away. And again, like I mentioned before, it's still performing, it's still going well, and really supporting that community in a multitude of ways.
An example from one of our other partners from PRT is Fahi based in Appalachia. They took part in a project that they call the Hickory Hill Recovery Center. And that center is a new construction project that is located in Emelina in Knott County, which is a persistent poverty county in Kentucky. And it consists of 2 dormitories with 16 beds each and 68 energy efficient apartments. And it serves 100 people a day. This facility has commercial kitchens, it has classrooms, laundry facilities, offices, and everything that the members may need. The Hickory Hill Recovery Center is a part of the Recovery Kentucky Initiative. The Recovery Kentucky Initiative was started in 2005 to address the issues of affordable housing in the state of Kentucky, and by focusing on the special needs of the homeless men who are addicted to drugs and/or alcohol. More than half of the homeless population in Kentucky suffers from substance abuse, and nearly 1/4 of them are considered chronically homeless. Recovery Kentucky uses recovery from addiction as part of a long-term solution to both of these issues together. The goals of the center are to help people recover from addiction and help them gain control of their lives to eventually become self-sufficient, productive, tax-paying, and law-abiding citizens of their community. There are 13 Recovery Kentucky centers across the Commonwealth offering a program model that includes peer support and daily living skills, training, job help, and practical living experiences, as well as supportive housing and recovery services. The Recovery Kentucky is a demanding program with a long-term recovery approach that is both peer-driven and professionally supervised. It utilizes the 12-step program and the Recovery Dynamics curriculum in a community atmosphere that emphasizes both personal responsibility and mutual accountability. Individuals typically reside for 1 year, 9 months to a year, and after 2 years, that's their max. For those who stay in the program, they're considered peer mentors, and they help current residents, or they're out working in the community as a result of this program. So this project actually highlights a capital stack example that Alex and I had brought up earlier. So for this project, Fahi specifically was the turnkey developer and put this entire development plan together. So this included $1.1 million in HUD home funds, a little over $683,000 from the Federal Home Loan Bank, $100,000 from deferred developer fees, $11,000 and general partner contribution, a $5.7 million equity investment from Fahi's Housing Equity Fund of Kentucky 3 LLC, and that's a total of $7.6 million and some change for this project. Fahi also provided a $7.5 million construction loan. This project helps 100 men each day in recovery from substance addiction and alcohol addiction with a 1-year success rate of 85%. As you can probably guess, putting that together and making sure everyone's T's were crossed and I's were dotted was extremely stressful in a hectic time, but that's the norm in rural, and that's what we have to face, and there are several experts in this field that are handling that on the daily and are not fazed by it at all. This program, the financing for the facility consisted of $6 million construction loan over 18 months at 5%, and permanent financing included $7.5 million provided from the Housing Equity Fund of Kentucky 3 LLC, and that generated a return of 6% over 15 years. Public funding of $1.1 million came from the Home Fund were grants, and $683,000 were private grants from the Federal Home Loan Bank of Cincinnati. So you can see how many different sectors and people took part in this partnership to get this project going. And this project made the community safer, it made folks that were suffering from addiction healthier, and it allowed them to become thought leaders, those who became peer mentors. So it's developing that local leadership that we need, and it's also having them participate more in a local economy that stimulates that area's economic well-being.
And I should also add that you mentioned a lot of different sources. There is no magic formula out there or a guidebook that tells you how to do it. It just requires creativity and a will to get it done.
Absolutely.
Did you want to chime in, Bernadette?
The only thing that I'll say is that just like what you heard from Emily and Alex, what we're talking about here is really building on the assets that are already within communities, right? We're not talking about bringing in. It's not an attraction approach. This is really an asset-based approach, and I think that's important to note across everyone on this dais is really talking about the resources that are within rural communities. And really, part of that is flipping a narrative around who lives in rural, who is in rural, who's contributing to rural, and really changing that to understand really there are people that are in rural that are innovative, that are doers, that get things done, just like they said. There's no magic way to get this done. It is a lot of work, it is a lot of trust building, but there are people that are doing this work, and these communities deserve to succeed. Much like if urban communities, if we put a lot of emphasis on urban communities and they're doing well, that doesn't need to be to the detriment of rural communities. And it really is a symbiotic relationship. And I think the more we work in that way through partnerships, the better we all will be.
Thank you. So I really appreciated the two examples that you both lifted up. And also, while they do demonstrate successes around financing, health care, mental health, I want to just bring into the conversation the broader role around community development, social and economic drivers that we know are so important to advancing health and well-being over time. And curious what you three would bring into the conversation around what are other areas we need to be paying attention to. Bonita, you talked about intersectionality of racism, placism, and classism. What other intersectionalities do we need to be paying attention to? And also, what are the ways that the work and the frame for the work need to fundamentally change if we're going to think about not just moving people into health, into prosperity, into opportunity, but actually transitioning the entire place to be place of opportunity, which is a fundamentally different level of change.
I think part of that is around shifting the conversation, shifting the narrative. I think there's a lot of this that is around, obviously, collaboration across multiple systems at multiple levels, at the local level as well as at different systems levels. So there's been a couple of pieces that at CSG we've really put a focus on through various case studies of really lifting up practitioners in the work that's happening on the ground, as well as through author briefs. And one brief particularly by some folks at University of Wisconsin, as well as Brian Dabson, really dive deeper into this question of thinking about what does it mean to think about health equity as related to economic development and community development. And really a couple of pieces have come out of that. Really, we have to think differently about how we measure success, right? And there's a whole thing that we've done at Aspen CSG around measuring success in rural communities is different than urban communities. What you think about a scale is going to be different, and you should really think about, your measuring decreases in divides, whether those are racial divides and class divides. So really thinking about your measurement terms as different. And also a core to that is how are you structuring your partnerships, right? How are our funders, whether that's philanthropic funders or governmental funders, how are you structuring your grants so that it really is having a more holistic approach? It's not just we're rural funders that are focused on health only, we're only going to think about hospital closures, right? It's not about that. It's a multi-layered issue. And much like you do, Katrina, through your portfolio, thinking about, well, how do all of these things intersect? So when you're thinking about health, workforce has a lot to do with that. Housing has a lot to do with that. Transportation, as we heard from Tom, has a lot to do with that. So how are you thinking about this intersectionality of these issues and building your grants around that, the intersectionality of that, encouraging partnerships across multiple different entities and agencies, and thinking about how you measure your success across all those different measurements, not just one focused on the number of hospitals that have closed, right? But how are you thinking about a cohesive approach to your funding is really critical. And then I also think, and I think, Emily, you mentioned it before, you know, really thinking about the flexibility of the funding streams that you're bringing together. Goes to how everything is put together and can really be beneficial and helpful. And then a couple of pieces that through a project that we're doing right now that have come up is really this thing about common language. So if you're in the healthcare sector, you might just strictly be focused on the nomenclature in that area, right? But we know that there's a difference between how health folks talk and how economic development folks talk and how community development folks talk. But is there some common language that we can all use around shared prosperity, shared outcomes, well-being of all within our community that can then help us get and bridge some of these conversations so it's not just siloed, but really bringing folks together. And then I mentioned thinking about those success measures that are based on collaboration.
Yeah, so thank you for bringing some of that up, Adina. That was great. In 2019, we saw one of the highest rates of rural hospital closures at 19 hospitals being closed. NIH did a study in 2020 that found that urban local health departments generated more revenue than rural local health departments, even when those rural local health departments were stratified into categories of large rural and small rural, even with the small rural having less revenue than the large rural category. And typically the small rural or the smaller rural category is where our PRT partners and national partners are doing the work that we're doing. This study also found that the rural local health departments depended more on state and federal funds, which are subject to change based on administration and the political climate at that time, whereas the urban local health departments depend on other forms of funding that are less subject to legislative change, and that generates for them a more stable revenue, as opposed to ours are a little less. Typically speaking, to get to the crux of your answer, when people think of federal funding for rural and health issues, USDA is the first agency to come to mind. And I want to challenge everyone here today to think about health in a more holistic way. While PRT partners do not claim to be health practitioners in any form or fashion, we do acknowledge that our work is indirectly affecting health in our communities that we serve. And with that, I want to take away the point that wastewater and water infrastructure work is rural health work. Broadband is rural health work. Affordable housing is rural health work. Small business lending and economic development are all rural health work. All of these sectors need to be included to address the rural health disparities in our communities. And with all of these sectors intersecting directly and indirectly with the health outcomes, more federal agencies need to prioritize funding to these communities and into the CDFIs that are serving these communities, much like the PRT partners and national partners. PRT often advocates for the 10-20-30 rule, where 10% of federal spending in each agency and within each program goes to persistent poverty counties specifically as a set-aside. And that will help us get the capital needed to make this holistic and system change approach. CDFIs have proven time and time again that with every $1 federal dollar, we can generate and leverage up to 8. So having that 10% could be truly pivotal in getting the transformational change we're truly striving to have.
I want to start answering the question by talking a little bit about hope, if I can. We are a family of community development organizations, all focused on increasing economic mobility in the Deep South. So there's Hope Enterprise Corporation, a CDFI loan fund that does a lot of the things you mentioned, affordable housing and small business lending, access to healthcare and healthy foods. But then there's also Hope Credit Union, which is the home to about 40,000 members, about half of which were unbanked or underbanked before coming to us. Still today, most have less than $1,000 in their checking or savings account combined. And they mostly live in rural communities and communities of color across the Deep South that are vastly under-resourced. And what we've had success in doing is combining that enterprise corporation with the credit union and with our third arm, the Hope Policy Institute, because we recognize that each entity alone could not solve these issues. It really takes all of them working together. And our policy and advocacy work is usually successful and only successful when we're able to talk about the strong track record that we've had in those other entities. And that's something that I've learned that CDFIs do across the board, that they do very well. They have a strong and long track record of having successes in these communities. And by investing in those CDFIs, you're not only investing in their direct work, but you're investing in building the power of the people in these communities whose voices have been silenced throughout most of the time and most of the things that we're working on. So that's one of the things that I like to encourage people to look up your CDFIs, your local ones, and figure out ways that you can get involved with those to uplift this work.
Nice. On that note, and that may be the message you want to leave people with, I don't know. But before we turn to questions from the audience, I want to just ask each of you to leave us with what your real kind of nugget take-home message is. I think you have a very friendly audience here. We have a very values-aligned audience here. So what do you want us to take away to make us think differently, act differently after today?
Yeah, I can start. I think when we think about health in the more holistic way that I had mentioned earlier, I want everyone to leave today, and I want you guys to talk with people in your organization and in your communities on how your work indirectly or directly impacts the health outcomes in your community, and how you can partner with a CDFI that's serving your community, and how you can advocate and how you can partner with and identify other partners to help you join this fight in helping to decrease these health disparities.
And that was a good point, but I'll restate it more directly as well. If we are going to truly advance rural health equity, we all have to be dedicated and all in doing so. So at Hope, our role is opening up pathways to economic mobility by providing access to capital. It's increasing ownership in these communities. It's in maintaining that strong track record. And I think each of us can ask ourselves, what is that role that we play? And consider that role being supporting your local CDFI. Consider figuring out how you can get involved and make meaningful and sustained investments in them to uplift this work.
And I would say, I would challenge us all to think about the work that we're doing in urban and rural in particular, and think about how race, place, and class show up in your work. And how those intersections, how are you in your job dismantling some of those discriminations that have been historically there? And what can you do? And I really do mean this. Everything that everyone in this room can do can make progress towards how we get rid of the structural barriers that have been in place for so long.
Thank you. Well, so on that note of progress, one of the questions we've gotten from the audience is, having talked about the many structural challenges rural communities face, can you give some examples of how you track progress toward equity, racially, geographically, and economically in the work that you do focused on health? So how do you track progress?
I think
Anybody?
I'll follow you.
You can go ahead.
Okay. Well, so I mentioned a bunch of the different stats about the successful hospital that we talked about, the number of jobs created, the number of patients served. And we can compare that to what those communities had before. We can also compare that to what other communities, what urban communities, what non-minority majority communities have. And we do that, and we do it often, and we're able to see how over time we are or are not living up to what these communities need and deserve, and how we might need to pivot. So that's usually what we look to, what those health disparities are, but also what some of the economic outputs and outcomes are in those communities as a result of us making these investments.
I think another thing that we think about, so just in full transparency, Aspen CSG, we lift a practitioner voice, so we're not on the ground. But one of the things that we've heard from some of our partners is that they also think about how can you track increases in civic engagement, right? How do people feel more welcome within their community? Are they engaging more in the civic process because of that? Does that mean that they're going to more community meetings? Are they involved in different processes? So I think that's another take on what Alex is saying, another way to track increases and decreases in race, place, and class divides as well.
Yeah, so in addition to what you had spoken about measuring to national and other places as a perspective, and what you had just spoken to, in addition to that, I think it's important to ask the community specifically how they want to measure success, and not assume that our standards are like an urban or metro standard is the goal that they have in mind. And so having that qualitative piece of data is absolutely essential, and I know a lot of our partners work on the ground themselves to get that idea and to be engaged with the communities and be aware of what their needs are and what they see as the best path forward to get to where they want to be.
I want to add just one thing. Bonita, you had mentioned earlier a brief that Aspen CSG put out related to measuring success.
Yep.
And I wonder if it's something you might be able to share after this through the channels, through the follow-ups, along with your Thrive Rural framework. I think one of the takeaways from that success measurement brief was that measurement progress and success need to be defined by the local community and need to be thought about in terms of the change in the community that the community wants to see, rather than driven by funders. And I think that's a really fundamental change that will get at the heart. And when it happens, it does get at the heart of understanding how these structural drivers are changing, because that's what people care about, even if they don't use that language. So another question we have from the audience feels quite important, and you started to touch on this a little bit in your very early remarks, Alex. But how can we get rural local governments to be better partners to CDFIs and to others advancing these aims, and other project funders seeking to make an impact on rural health and health equity?
Yeah, so we've found that the municipal governments are usually pretty good partners for us when we're able to give them access to the tools that they need. And they have a lot of different priorities that are always constantly competing with one another. But when we can point out the need and show the resources and come and bring community voice to the conversation, we get a lot of support there. At the state level, where we are, it's a different story. And through policy and advocacy pushes, we sometimes have successes, but again, it's making the case around the need, but also this is a good investment in your community. These are jobs that are being created. So speaking the language of whoever is listening, but ultimately, when it comes to individual health clinics or hospitals or a community, we are usually able to make a better case but when we say we need to expand Medicaid or we need to do these other things, these other structural things, that's where we have a bigger challenge.
I think at the very basic level, it really depends on trust and partnerships. And if we can show them that we're here to help and give you the tools that you need to do the work that you want to do to get the results you want to see from your community and constituents' perspective, that partnership is much stronger and there's a lot more trust, and then the empowerment and the hope can come after that. But first we have to have that layer of trust and partnership.
And you have to move at the speed of trust, which may not fit with your timeline.
I would just say, I think that the framework that we talked about really gets at the local level and the systems level. And I think both of y'all talked about this in different ways, right? Like, it doesn't happen quickly. And at the local level, there's a lot that has to be right to move things at the state level. And I think it's important to understand the dynamics of the community in which you're working within. And that is critical. And why you have CDFI partners that are on the ground doing that work that understand that, because you can't move policy at the state level if the local people don't want it and they're not coordinated to get there.
And to build on that, Bonita, I think something I've heard Bill talk about a lot, the CEO of Hope, is the importance of people having in these communities that are most affected by these policies and inequities, having voice and having influence. And there is an unparalleled opportunity right now with actually so much more resource going to CDFIs and other institutions. And if we're not intentional about how we channel those resources right now, and if we're not intentional about holding government accountable for using those resources in ways that closes disparity gaps, then we could be perpetuating historical inequities rather than closing those gaps. And so I think recognizing the need and value of building voice and community power to hold government accountable, in addition to government being a helpful partner and ally, is incredibly important. And the role that many CDFIs play in supporting ownership, because we know ownership is a core driver to increasing civic engagement and participation, whether that's housing ownership or whether that's collective ownership of a credit union, for example. So I just wanted to throw that in as another important part of the answer to that question. So just one final question, and then we're going to close up. You've mentioned what it takes to put resources together in some of your stories of success. Can you talk more about how rural communities can build the capacity that's needed to raise that kind of resource and to launch these kinds of initiatives? So what does it take to build that capacity?
Again, I think it falls back to partnership, right? I think there's a lot of dynamics that are hard to manage in terms of figuring out if there's historical context there that may impede that partnership and that trust, or financial trauma, or anything around asking for help. But once you get that partnership, you're really able to start figuring out what they want, what they need to get what they want, and then building upon that with them and showing them how to do it, and then stepping back and letting them take control of their success. So that way they are empowered to spread that success themselves.
I'm reminded of a community in the Mississippi Delta. Outside of Moorhead, Mississippi, it's a community called Eastmore, and encourage you guys to look it up when you get a chance. But this community had been failed in every way you can imagine, by the local government, by the developers doing the work there, by the state and federal government, who had all promised to do things that would improve conditions there, and it just did not happen. Ultimately, the residents grew more than tired of it and came together and decided to ask for help. And in doing so, just them organizing, like you said, them partnering together, them showing up, realizing that their collective voices were more powerful than them just, yelling on their own. They were able to move the needle. They were able to get the resources to rebuild it, and they started inviting people like Hope to the table to then come. And what we loved about this story is that this was their thing. They did it, and they told us how we needed to show up, and we did. And they found a lawyer and told them how they needed to show up, and they did. And they found their collective voice and the power that came with that. And I think if we can find more stories like that, or if encourage communities to use that collective voice, then we just give them the access to the tools, like you said, and let them run with it.
I think this was a question for the CD5s, but I just want to say something. I think we have to challenge ourselves to think about capacity building differently. And I say capacity building in air quotes, because Alex, your story is so, it hits the nail on the head for me. It is not about building the capacity of the community. The community already had the capacity that they needed. It was tools that they needed to come in to help them. But the capacity was there within the community, within the voice, the ability for those folks to come together. They had agency to do so. And so I think I challenge us all to think about this term capacity building and what does that actually mean? Because the people on the ground in rural communities know what they're doing. They've been doing a lot with less for a long time. And so it is upon us to think about what are the tools that we then need to provide to help them. But they already they've been doing it without us for a long time.
Yeah. And get creative with what tools means.
Yes.
Yes, we can make you a loan, but we can also help you write that strategic plan that you're going to
Thank
need
you.
to apply for that federal grant.
Exactly.
We can also do these other things for you too. And encouraging other institutions to do the same goes a long way.
Thank you. So on that note, I'll just thank you all, and thanks again to you all for hosting the panel. There were a couple of questions we didn't get to, so I'll check with the hosts to see if there's a way we can circle back with answers to the questions online after this.
Thank you.
Thank you.
Welcome again, everyone. Our second panel today brings together a diverse group of organizations such as community health centers and nonprofit organizations to discuss their service models and challenges and opportunities that they face in promoting rural health issues in their communities. I'm Ann Janad with the Urban Institute, and I'm fortunate to work on policy-relevant research that promotes rural community equity, resilience, and sustainability, especially around environmental and climate change issues. I'm very pleased to welcome our three panelists to discuss promising models to address rural health challenges, including barriers and opportunities in promoting rural health issues in their communities. Patty Molina is the Senior Director of Community Services for the Mariposa Community Health Center in Santa Cruz County, Arizona. Mariposa Community Health Center provides patient-centered and culturally appropriate primary care and community-based education services across Southern Arizona. Allison Seegers is the Executive Director of Rural Health Projects Incorporated. Rural Health Projects works to improve access to and quality of healthcare services for rural Oklahomans through collaboration, advocacy, education, recruitment, and training. And Mary Otwell is the president of the board of directors for the School-Based Health Alliance in Arkansas, which advocates for the provision of high-quality, easily accessible, and coordinated health services to children in Arkansas schools. Thank you all so much for joining us today. So to start, can you tell us about the rural populations that you work with? What are some of the health challenges that they face, and which service models are working well for you to meet their needs? And maybe we can just start with Patty and go down the line.
Sure. So the population that Mariposa Community Health Center serves is primarily Hispanic, Mexican-American immigrant. Mariposa Community Health Center is based in Santa Cruz County, which is the smallest county in the state of Arizona near the border in Mexico. So a lot of our population is Hispanic, about 85%. Models that work best with us or have been quite successful in terms of us meeting the health needs of that community is the utilization of community health workers in my particular department, making sure that they are using all of those class standards, culturally linguistic, standards that are needed to best meet those hard to reach populations in our community, because it is a rural community, and just trying to serve everyone as best as we can.
So the School-Based Health Alliance of Arkansas serves communities throughout the state. In Arkansas, it's about 41% of our population is in rural areas, and that's about 62 out of the 75 counties. And in that, only about 20% of the state's primary care physicians are located in those rural communities. So we have a huge disparity there. And we have this model of school-based health clinics throughout the state and throughout the nation, working in both rural and urban communities to bring affordable, accessible, equitable healthcare right there to our communities that need it most. That's sometimes a full doctor's office, dentist, eye doctor in the school. Sometimes it's a mobile unit, sometimes it's school linked, where the school provides transportation to a nearby clinic. But most often it's that traditional school-based brick and mortar, where it's a full-blown clinic in a school, where students are not missing full days of school to go to wherever the closest provider is, whether it's the next county over, and parents are able to not have to take off work. So we're helping the whole family out there. And in a lot of our school-based health clinics, they not only serve the students at that school, but they serve the whole community. So we're really getting across the board there. And then we're really changing the generations of the culture of health for the communities. Whereas we're seeing these families who grew up using these school-based health clinics, they now have students in those schools and already know to go to the doctor every year for a physical. They already know to go to the dentist twice a year. So we're truly changing the culture of health in these rural communities.
Our office works with a lot of different rural communities, focusing in Northwest Oklahoma, but Garfield County, where our office is located, is home to either the 4th or 5th largest population in the contiguous U.S., depending on who you ask, of those from the Marshall Islands. And just a brief history, the U.S. tested 67 nuclear weapons on one of the islands within that country. And it created radiation fallout for them and some other communities within range of that. So they have a unique citizenship status with the U.S., covered under a COFA treaty, and they have high rates of diabetes. There's some high rates of cancer, lower life expectancy, genetic mutations from the radiation, so just lots of chronic disease type things too. They've been in our community since the 1970s, but there are the largest community in Springdale, Arkansas. They predate that. Our population predates Arkansas's, but we have had as a community, public health community, we've had difficulties reaching that population. And so from some of our providers, they were considered non-compliant because they didn't follow instruction or wouldn't show up to appointments, things like that, they were labeled. And so we've been trying to address those issues. And in 2014, we hired our first community health worker who was from that population and just had such a great heart for caring for her community. And to no one's surprise here, people started started showing up to community education opportunities, and those were taught in Marshallese. And we started seeing real changes in blood work and all of those other things, positive changes in that community because of that community health worker. And since then, we've hired additional community health workers and also have some Spanish-speaking community health workers. So that's the work we're doing. Thank you all so much. You're touching on it. I wonder if you could unpack a little bit. Like I'm hearing like the role of cultural competency really coming through, especially with the community health worker model. But it sounds like it's across the board. I'm wondering if you could speak just a little bit more directly to that in your work. Like what's the importance of it? How are you seeing it impact the populations that you're working with?
I think just having someone from that community who is trusted. Trust is such a huge important role from a community health worker, and someone who's trusted, who speaks the language, who understands the culture,
that piece is so important to cultural humility and who can help teach those who aren't from those communities about the culture. So I think for us, that's the important tie-in there.
Yeah, I agree with that. So our population is about 85% Hispanic, and so where we're at, you can just imagine it's difficult to get providers and non-providers who speak the language to stay there, and then of course to try to get all of the care that patients are needing. And so the community health worker helps to reach out and helps to really navigate that system for them so that they're able to really find the health care that they need. And if we're unable to provide it in our area, make sure that we have the resources available to get them to where they need to get the services that they need.
Yeah, I mean, I definitely agree. I think for a lot of school-based health clinics, some of them fail. You really need the support of the community, and the community has to want something like that in there, whether it's backing from the school or from the people who live there, who are often the same. But you really need their buy-in and their advice on what works for them. We heard a lot about that earlier on what the community wants.
Excellent. I want to turn to one of our themes for today, and that's the role of partnerships. And just quickly plug the team's new guidebook, as we're hearing about, for leveraging partnerships and data to improve rural health and well-being, which does provide some great resources for identifying partners to coordinate and improve rural health services delivery. For the panel, can you tell us about the role of partnerships in successful models or practices that you've adopted? What kinds of organizations, what kinds of agencies, funders can be really valued partners for health providers, and what opportunities exist to really establish and deepen these relationships? Let's start with Allison and maybe come this way.
For us, we really try to meet the people where they are, where they feel safe, where they feel comfortable. So for us, we do a lot of partnership with our local free clinic, who up until our state adopted Medicaid expansion, where a lot of our Marshallese population sought treatment. So it was a trusted source. We're also working with our federally qualified health center very frequently. They're a great partner. We actually have a partner in the room today, Hoodia Health. Ed Connors with Access Me Care we're utilizing a virtual social work platform. It serves as kind of a living resource. Our Marshallese population is very techie, so that's really helpful for that sort of thing. One of our hospital systems has been great partners and do some of our grant writing for us. So they have been exceptional. They have a vested interest in our community and want to see improvements made. So they've been great. We're partnering with our Loaves and Fishes Food Bank, who provide extra points if people attend our classes. So that's amazing. Our Garfield County Health Department is really helpful. Our United Way hosts nonprofit meetings monthly or every other month, so we can hear from other people and not duplicate services. That's really great. Our public school systems, our area health education centers. HRSA has been a funder for some of our projects, which has helped jumpstart a lot of our things that we have going on. And people like Dr. Sheldon Ricklin, who is one of two physicians who are Marshallese, but he lives and works in Springdale and gets on calls and gives us suggestions and has done stuff for our community. So lots of amazing partners that we're happy to work with.
So our probably biggest partners for the Health Alliance, other than our individual schools that host health clinics, school-based health clinics, are Department of Education and Department of Health. They're our biggest funder, they're our biggest advocate, our biggest supporter on both the Alliance level and with the clinics themselves. But we have a lot of grants locally and federally. Our other really biggest partner are just providers, whether it's FQHCs, hospitals, or local independent providers who come from that area. And then just other local nonprofits and organizations that bring health education to the communities, whether it's oral health education, obesity prevention, nutrition, tobacco cessation or prevention. But yeah.
So we actually were talking about partnerships and the importance of partnerships earlier today. And so in our small community, you can just imagine that we need to make sure that we're not replicating services and that we're not competing for specific grant funds that are available to us either. So it's really important for us to grow and establish these partnerships all around the community. So we have various different partners, the food bank, the schools. We only have one critical access hospital in our area, really important partnership right there. We also have some behavioral health agencies. And then just in general with some of the funding that we have state, federal, and then private foundation funds. It's important for us to create these partnerships through there so that we're able to build upon what we're using the resources for our small community. We heard the panel before talking about the Kentucky Recovery Model. That's a model that we have our core funding, so that's something that we've been trying to establish in our community, so that's important right there. We have funding for diabetes education. For example, what we're trying to do with that is do a fruit and vegetable prescription program. And so we were able to partner with Blue Cross Blue Shield to be able to provide these vouchers for our patients. And one of the things that we did is we partnered with local grocery stores, family-owned grocery stores, not any of the big boxes, because we wanted to support local, our food bank, and then our small little farmers market. And so just those types of collaborations are really successful for us.
Fabulous. Can you take us back in time? Like, you've listed this laundry list of fabulous partnerships that you're working with. Take us back in time. What were the key ingredients for establishing these relationships? Or thinking about your long-term partners that have been with you for a while, what are the key ingredients for deepening these relationships?
So in Arkansas, the school-based health, modern-day school-based health clinics really started through Department of Ed and Department of Health. I just learned about this the other day, where they got together for 4 days and hashed out how this was going to look. And so they did a really pointed effort to make up what school-based health would look like in Arkansas. And that was 15 years ago next year. And then the School-Based Health Alliance came from that a few years later, and our partnership has been like this ever since. But
I think for us, to deepen our partnerships and the way we've been good partners is just being good partners. So we have a tight group of people that I know I can call on, and they can call on me, and we're going to do the work that they ask us to, or we're going to be there to help them with whatever they need, and the same for them for us. So just making sure that we're doing what we say we're going to, and that we're there for them like they're there for us. And just like you mentioned, not duplicating services is really important. That's why we meet regularly, to just make sure that we're all working toward the goal and not in different directions. So, I forgot to mention too, one of our partners is the Micronesian Coalition. They've been a strong partner. They started several years ago, but they've been really helpful with helping us reach the population too.
So for us, the FQHC has been around since 1980. The particular department that does more of the community health services out in the community that I oversee has been around since 1991. And it actually came about through HRSA funding to help establish that community health worker model that I'm talking about now. So that's been since 91. And really focusing on women's health care issues. So anything from bringing women in to come in for prenatal care, postnatal care, promoting breastfeeding support, making sure they're coming in for mammograms, cervical cancer screening, et cetera. And so through those partnerships, when that first started, that is something that we had to continue throughout the years. And again, because it's such a small community, making sure that you're not duplicating services and that you're making sure that you're growing within what we have housed inside of the county, because we don't want to bring in partners from outside that could be more competitive for us. And then, of course, making sure that we don't get funding if they will get that.
Can you speak a little bit more to that funding piece? Like, it's a delicate dance. You want to obviously collaborate where appropriate and build on strengths, but like to what you've said a few times now, like you also don't want to step on toes. Can you speak to partnerships in going after funding and lessons that you've learned there? How have you collaborated and what's working?
So for most of our funding, if it's federal funding, for example, I'll talk about our core funding right now. Implementation, we have an implementation funding for opioid use disorder, and then of course our psychostimulant as well. So we have a consortium that was created originally with 15 partners and has now since grown. So we have all different types of partners in there, not just behavioral health, medical providers, but we have first responders, we have sheriff, law enforcement, et cetera. And so what's important there is that we have our different partners that are working on the treatment, the recovery, and the workforce, and making sure that each one of them is aligned to work exactly and only in those areas, and then of course to come together when it's needed, but not step over each other's toes, not tell each other how to do things, and then of course making sure that they're not competing for funding that is going to duplicate those same services, making the programs that you currently have in place not a success. And then the more important thing is about an hour away from us is the most urban area. That's Tucson, Arizona. Those partners can easily access a lot of these funding sources and then want to serve our community when they don't even know the community. So that is a threat to us.
Yes, absolutely. Anything to add, Allison and Mary?
I think just for us, it's about knowing our limitations and our partners' limitations and just kind of staying in our own lanes and making sure that we are doing the best we can do with the resources that we have, knowing that our partners are going to fill in the blanks, and the same with them for us. So as a nonprofit, we offer a little bit more flexibility than like our health department, for example. So there are times when we get asked to step in when things are needed maybe a little bit more quickly, or we go through them for things that maybe need a little bit more of a powerhouse backing, I guess you could say. So we know what our role is, and we try to stick with that.
Yeah, I think it's very similar for our nonprofit. We work really closely with the state departments, but there's certain like grants and opportunities that we can bring to our local school-based health clinics that our state departments may not be able to be involved in. So we both look out for each other and what would be a better fit for you to start this initiative, what would be better for us. Strengthening the partnerships that way.
Excellent. So thinking now about the successes that you're seeing with the models that we've been discussing and the benefits of the partnerships that we've been discussing, I'm sure that there's certainly more that you would each identify that could still advance rural health equity in your communities. I'm wondering if you can tell us about other opportunities that you see to address some of the rural-specific health challenges in your communities. Can you lift up any tools, any resources that would be most useful to move these forward? So what are you seeing, and what solutions do you see for this?
Yeah, so two main things I think for us. One is the reimbursement, Medicaid reimbursement. For our students, they require PCP referral, and our school-based health clinics aren't there to take away from other doctors in the area. They are not there to steal patients. They're there to catch those kids who are falling through the cracks, the kids who are unable to access health care, whether it be by transportation or ability to pay. So some states no longer require that PCP referral specifically for school-based health clinics. So we're seeing some states already move in that direction, but needing to see that more widespread. And then second is providers. We don't always have the amount of providers that we need in rural areas, but some things that we're doing are partnering with medical schools and local hospitals and bringing medical students and residents to school-based health clinics, exposing them to some non-traditional healthcare options, and hoping that they'll take that and run with it, maybe bring it back to where they're from or go to some of those rural areas. Another opportunity is partnering with those medical schools again, to maybe offer some sort of incentive for people to stay in the state after they graduate.
Ours is along the same line of kind of the funding issue. As we move into value-based care as a nation, community health workers get to the heart of those social determinants of health issues that make up, I don't remember what the number is from the Robert John, 20% of our health, overall health. And so just funding those positions and figuring out payment models for that, I think would just be so helpful to the work that we're doing.
So traditionally, community health workers have been doing a lot of the work in a lot of different health settings for free, not really getting paid. My particular department is 100% grant funded. So like I said, we have state, federal, and private foundation grants. So I build into every budget, making sure that community health workers are in there as well. The important thing right now is talking about reimbursement for some of the services that CHWs are doing. In a FQHC setting, of course, that's a little bit more difficult because of the all-inclusive rate that we have, but that is something that our state is trying to work on right there for reimbursement through either our Medicaid or state Medicaid program. I'm sorry. The state's Medicaid program. Access is what I was trying to say in my head, Arizona Cost Containment Service. And so then that is one of the things that we need to worry about right there, is just making sure that those services are there. We also have value-based contracts, and we have a different model where we are doing some types of services with CHWs for reimbursement through there, but not everything is billable, so that's always an issue.
Yeah. Excellent. We have a few minutes left, and we'd love to be able to chat with our audience here in the room and virtually and answer questions that folks have lifted up. I want to remind folks in the room that you can scan the QR code that's on your table and enter your questions there, so please don't be shy. And online as well, joining us virtually, please share your questions with us. I think to kick things off, I'm wondering, you're all in different states with different health needs, different policy landscapes, different partner networks. I'm wondering if you can share any examples of successes in implementing the various models we've been discussing in the midst of what might be difficult contexts, whatever that looks like in your community. You could talk about, for example, successes that your organizations have achieved despite maybe not having all of the resources that you may hope for. And just as the spirit moves, whoever feels that this is a good question for them, we'd love to hear.
I think some successes we've had is I keep going back to this partnership with our state departments, the Department of Health and Department of Ed, but that's a really big deal, and it doesn't happen in every state the same way. The school-based health alliances are set up very differently state to state, but in Arkansas, that partnership is really strong. And additionally, FQHCs, we're seeing more and more of those in our state really take heed of this school-based health clinic movement and establish school-based health clinics in areas that don't have that funding from the state even. They're willing to put their time and money into it.
I think that some of the challenges that we're seeing right now, and I know that Tom brought this up in his presentation about the obstetrics care in our area. We lost, because of COVID, we lost a lot of our OB providers in our area, and for a while there we were just working with one OB provider, so you can just imagine. It's a small county. We only have about maybe 600 births a year, so it isn't much. We had to contract out to a laborist company, so you can just imagine how expensive that could be. But making sure that we have that need in the community met is what's important. So, but keeping providers, quality providers in our areas is always a challenge right there, but really looking at how we can partner up with like the laborist company, and then doing residential programs with the local institute for residents. That's important right there.
Echo all of those things. Just our partnerships are really vital, and our state was late in accepting the expansion of Medicaid, And that was led through a statewide organization that just decided enough was enough. And they just did all of the marketing, and it's really been beneficial to us. Our Marshallese population, because of some legislation recently, is now able to access our state Medicaid system. And so we've been enrolling people in Medicaid. So just the efforts of everyone are so important, and we do our part.
I think we have time for one more question. This is about, your perspectives on both opportunities as well as challenges in pursuing program and grant funding. So not service reimbursement. What types of investments, if we're dreaming or envisioning here, what types of investments would be helpful in the future to really lift up and expand the services that you're already doing, build on your successes? What would you hope to see?
For us, I'm going to think some type of mobile type unit. We just recently got a dental mobile unit. It's not up and operational yet. There is no public transportation where we're at in Santa Cruz County, and not everyone has a vehicle, so that makes it really hard. It's also not a very walkable community either. So there's challenges right there. There's private-owned bus companies that you can pay to get to where you need to be, but that's not always where you need to be, that access to right there. So if we can have some type of mobile type service where we could bring the services to those areas of the population that's needed, that would be ideal.
Yeah, so I think a lot of our school-based health, or schools that even want a school-based health clinic, may not have room to house a school-based health clinic. So some sort of funding to be able to build an additional building. I mean, it's really expensive to do, but sometimes that's the only option. So yeah, physical infrastructure. Yeah.
I think one thing for us would be investing in health technology, the platform that I talked about earlier, just making it easier for people to connect with resources would be so helpful. And as we more heavily rely on technology, just trying to, we have a lot of resources in our community, but we don't always know what those are or what they're doing. And so just being able to connect to those resources and then connect people to those resources, I think would be very helpful.
Excellent. Excellent. I think we're coming right in, landing the plane right on time. So thank you so much to our panel. I'd like to thank everyone here also for being with us today. We're going to move to a short break now, so please feel free. Restrooms are out the door, refreshments are out the door. Please help yourself. And then we will come back for our third panel on partnerships for identifying needs and tracking progress on promoting rural health equity. So thanks so much to our panel, and thanks for everyone for being here. Thank you.
Okay, hello everyone, and welcome back to our third and final panel today. I am Anna Morgan with the Urban Institute, where I am fortunate to work on research related to affordable housing, place-based initiatives, and rural community well-being. It is my pleasure to welcome our three panelists to discuss partnerships for identifying needs and tracking progress, and the importance of leveraging data to promote rural health equity. So on the stage with me, I have Elaine Crutchfield from Communities Unlimited, Carla Willis, who is a Principal Research Associate in the Health Policy Center here at the Urban Institute, and Sydney Howard, who is a Data Research Analyst for the Center of Excellence in Rural Health at the University of Kentucky. So thank you all for being with us here today. I'm really looking forward to our discussion. So throughout our time today, during this convening, we've heard about the importance of leveraging resources and creating partnerships to promote rural health and rural health equity. Another key piece of this work is creating programs that are suited to the specific communities they are located in and measuring the impact of those programs. Would you please each think about a certain solution you've been able to track and measure and share the journey of creating that solution with us? In particular, would you tell us about the data used to identify the issue, how you leverage that data to design your solution, and how you're tracking and measuring that progress? So Elaine, we can start with you and work our way down.
Okay, thank you. When thinking about capturing data in programs or interventions, for me, it's critically important that the process be embedded into the day-to-day activities of the folks that are working in the field, that are working with their clients, that we're not adding another layer to what they have to already do. For example, in a project where we were supporting the introduction of healthy foods to families living in our target communities, along with education designed to help older children and parents and or caregivers understand how to prepare healthy meals, introducing new vegetables, etc. The idea was, we're going to supplement purchasing for a while. We're going to ask that you participate in training. This was done through an amazing collaboration with school-based nurses. So they had the relationship and the trust of the family. And then we're like, try some new things, see how it works. Consider then, is it doable within your budget? We were very interested in health outcomes, children that were struggling with high blood pressure or were perhaps pre-diabetic or severely obese, along with the others in the household. Did they adopt the healthy eating habits? Well, we're asking for medical data. That's private, personal, protected. We're asking for information about what they do in their homes, how they shop, how they cook, so on and so forth. Huge challenge. We were very, very fortunate that we found a provider that could give us a type of coupon. They're called vouchers for veggies. So they could track what participants purchased at the store, not the participant, but what was purchased across everyone in the program. And our school-based partners, who were absolute community-based champions for healthy eating and the impacts, stepped in and formed this fascinating bridge where we had no idea who the folks were, who the children were, what school were they, middle, junior, high school. We did know age, height, weight, blood pressure, A1C, et cetera, because it was completely blind for us. We were able to work out a very creative solution for a nonprofit that was passing through grant funds to our school-based partner who would assign those vouchers. And it took a lot of work. We had forms that collected information designed on iPads that were encrypted. So we captured qualitative feedback from the families when they came in to meet with their counselor and the school-based nurse. So it was, tell us what you thought. What did you try? No idea which family it is necessarily, just a participant number provided by that partner. All of this was designed before we ever started, and it worked because we had a partner and a community champion invested in reaching out to the clients and seeing change. So invested, she even designed a completely different set of survey questions at the end of the program. And she is maintaining contact with those families and those children into the following school year, even though the grant funding for that program ended. So the lesson learned was make it as easy for your partners as possible, leverage your technology, don't forget your qualitative information, and don't give up. There's ways around PII and all of the challenges that we have with data and evaluation that can still result in a valid data set from which we can learn and evaluate the intervention. That's my story.
So prior to joining the Urban Institute, I've only been here about 1.5 years. And prior to that, I was with Georgia Medicaid for about 3 years. So my last role there was as the Director of Performance, Quality, and Outcomes. But I came in as like the Senior Manager of Data Analytics. So we had this data shop where we were small but mighty, really trying to do the work of understanding the troves of data that are available in Georgia Medicaid and in most Medicaid agencies. So one of the things, or the example that I'd like to share with you today, is the work that we did around addressing low rates of postpartum care visits for our moms and doing the work to try to increase those rates, because we saw some real clear connections between postpartum visits and our maternal mortality rates. So a little bit of a backstory is we had taken at least 1 year or better to really own our story around who are our moms, who is dying, and what role does Medicaid have to play in changing the way that we did business so that we could be there for our moms. So we put our hearts and our souls into this document called the Quality Strategy. And in this quality strategy, we made some really bold assertions where we told everybody, we aired all of our dirty laundry. We told everybody how abysmal we were performing on postpartum care. So much so, our HEDIS measures, which are the metrics that most Medicaid agencies use to track our progress, for several years, we were below the 25th percentile. So that's really bad, right? So it's like F year after year. And rather than hiding from that, we decided to own it, because we also knew that the vast majority of the moms who passed away after the birth had their delivery paid for by Medicaid. In Georgia, that was 68% of the moms who passed away had their births paid for, their deliveries were paid for by Medicaid. So we knew that we had a role to play. And rather than kind of sticking our head in the sand and, you know, doing this kind of woe is me dance, we decided to go, we decided to do something. So CMS actually had an initiative where they were asking states if they were interested in participating in a year-long performance improvement opportunity. So it was called like Improving Postpartum Care. There was an application process, an interview process where they asked all these hard questions, and we just went for it. And, we just figured, worst they can tell us is no. We ended up being one of 9 states that were selected for this unique opportunity. The work required that each state come up with performance improvement activities that specifically were designed to improve postpartum care rates in their state. So we started asking people, where should we focus? Because we had these big numbers. We had these aggregate for the state numbers. Or, one level down was we could understand what was going on at the managed care level, but we didn't know what was going on at the county level. So the first thing we did was we started listening to our providers. And our providers were saying, yes, it's terrible in the state, but it's extra terrible in rural Georgia for many of the reasons that I'm sure you guys know, right? So we have challenges around access to care. We've got heavy disease burden due to a pent-up demand. All of these things were in play. So we used the wisdom of the folks that we have been partnering with over several years to say, we're going to focus our efforts on rural Georgia. We then asked our managed care companies to partner with us and create quality improvement teams to identify a research question, identify the data that was specific to that county, and then come up with some solutions for addressing the problem. We worked on that for about a year, and we found out that that was a very heavy lift, but we ended up relaunching the whole thing. CMS gave us funding for a second year. Thank you, CMS. But with the new funding, we had this revised approach, and we said we need to provide the managed care companies with the agency to do what they know they need to do. So that meant that the managed care companies got an opportunity to really frame the aim in the way that made sense for them. Rather than looking at a county, they were allowed to look at regions. So Georgia has 159 counties. So the problem is that you might only have a few people at some point in their pregnancy in a distinct county, but you might get a bigger spread and more impact for that performance improvement opportunity if you look regionally as opposed to within a county. So all of these things were things that we had to learn along the way, but we used data to try to figure out, how do we hone into the things that would make the greatest impact among the communities that we desperately want to serve. So the long and short of it is that each one of the managed care companies came up with a revised approach. We've actually seen some improvements in the postpartum visit rate for the folks who were engaged in these particular pilots. And each one of the managed care companies have now incorporated this into the way that they do business. So here's an opportunity to start small, but then to listen to the communities around you in order to scale up and serve a greater number of Georgia moms. Thanks.
The Center of Excellence in Rural Health sits in Hazard, Kentucky, which is in eastern Kentucky in the heart of Appalachia. We serve 102 rural counties across the state. There's 120 counties in total, so it's a very rural state. We reach all the way across Kentucky, so it's not just focused in that area. The center was established in the 90s to address healthcare concerns, and it's no secret that healthcare workforce is one of those concerns. And so the center is mandated to do workforce, specifically healthcare workforce investigations. And about 6 years ago, we noticed that there are workforce there are workforce studies being done, but like Carla said, not necessarily at the county level, more at the state level. And so what we really wanted to do was find a way to systematically go through the data and see what the workforce landscape really was across the state. So what we did was we turned to the licensure boards that the state has. The three that we mostly focus on are dental, medical, and nursing licensure boards. So we request that data from them and analyze it in a way that makes sense so that we can get the data to the people who need it most to be making decisions. Sometimes we have data just for data's sake, but the center does a really good job of presenting data in a way that each audience can understand and can use it for whatever the purpose is. The center also serves as the Kentucky Office of Rural Health. It's the federally designated center of the Kentucky Office of Rural Health. And they have a student loan repayment program that they provide from their office. And the center believes wholeheartedly in giving student loan repayment as retention for providers. So we took some of this data that we have been collecting and analyzing and presenting over the last 6-7 years to the legislative floor in Kentucky, and we actually received $2 million in a healthcare worker loan relief program. For Eastern Kentucky, there's a lot of data that suggests that if people are working and living in rural, they tend to stay and live in rural. So we want to attract people to come work and live where they're most needed.
Thank you, and thank you all for sharing all these innovative solutions. So I'm curious, as programs that require data, I'm wondering if you could talk a little bit about the challenges of collecting, tracking, and leveraging data to improve rural health. And something you touched on, Sydney, was about how the center does a good job communicating data. And so I'm wondering if you could talk, one of the things you could talk about as a challenge is communicating data in a clear and effective and accessible way to folks outside of your program, outside of your organization. So maybe we could start with you, Sydney.
Sure, yeah. So within the center, like I said, we do a really good job of communicating to the right audience. For example, we have something called Appalachian Research Day, where we have community participatory-based researchers come in and give back the findings that they've found from these studies that they do within rural Kentucky. It's a really great day. We include the community. And so in thinking of the research, the workforce research that we do, we also like to do the same thing. So we communicate them in not only Word documents that go on forever, but also as infographics that our communities can use so that they can see where the pockets of providers are. We also do a lot of presentations orally and like this. And then we also do bites of information for legislators that they can really take in quickly in the time that you have with them. Here are the high points. So you really have to tailor your messaging for whatever it is that you want to get across to whatever audience. And I think that that's really important.
Thank you. Carla or Elaine, anything to
Sure.
add?
So I would just add a lot of the data that we use, it's all based on like HEDIS metrics, you know. So that ends up being like a buzzword that only folks kind of like in that space use. And so it's an information hurdle to already get over. So what we saw was that one, that data was not entirely accessible because it doesn't resonate with you unless you're doing it every day. So one of the things that we did for just overall was we took that information that we have to produce every year for reporting to the federal government, and we just created dashboards because we were getting a lot of questions from our external partners who were concerned, and rightfully so. It was just like, I need to know what you're doing about this particular issue. And there was only so many times you can say, hey, it's in the annual technical report. And don't you just love reading all 117 pages of it, right? So what we did is we said, you know, we can fix this. And I have to say, CMS came to the rescue again and said, you know, we are going to provide an opportunity for, it was like these technical grants where they provided access to super smart people who would give us the skills and train us on the technical components that we were lacking. So one of the things that we wanted to do was we wanted to produce these dashboards, and none of us knew how to do it. So thanks to CMS, they gave us access to a company that provided us with a team. We met with that team like every week. I'm sure it was for like an entire year. And from that, we were able to lift up one of the folks on our team who became kind of the SME around data visualization. And then we were able to take that information from those annual technical reports and put it in a user-friendly dashboard. So every year, you would have two things coming out. You would have the big technical report, all 117 pages, and then you would have this one-page dashboard that was easy for people to read. And, you know, to go one step further, we reached out to some friends who were in the community, and we said, you know, we want to pilot this with you guys because we think this makes sense, but we might be asking the wrong questions. And so we leveraged their skill set at being able to surface what's most meaningful to people on the ground. And then based on their suggestions, we made modifications to that dashboard before releasing it publicly. So in that way, we were trying to make data accessible and make it meaningful for the work that many of us are trying to do, and recognizing that we don't do this work in silos or by ourselves.
Anything to add, Elaine?
Ditto. I like so many. I agree with so many of the things that both of you were sharing. I think what I could add that might be unique is that, you know, I love data. I'm a self-described data nerd. I would read that technical report.
All 117 pages?
And then I would so value that dashboard. Mm-hmm. Because we've talked a lot today about listening to the people and the places where we're trying to fuel transformation. Hearing them, they know what they need. They know what their capacity is. They may not use the same terms we do or refer to data in the same way that we're accustomed to putting it in cute tables and charts and running our stats, but they know their community and they know the needs. So for us, the greatest challenge is capturing that sort of qualitative, soft data that comes in through town hall meetings and discussions and marrying that with what data is available, which sometimes in, what were they, sub-rural communities, I believe you referred to. If you look down at your stats, the data is really just not valid. But that's okay, because it's a place to start. And then sharing data in a way that your partners understand it and can then provide comment and add to, so that it's this collaborative process. It's hard to manage the qualitative component and all of the comments. And how do you drill that down to something meaningful that you can track over time? And while it's a challenge, it's worth doing, because in many communities, it can also be the way to open the door to perhaps create some community researchers that, you know, is like, okay, I can do numbers. I can handle some math and some stats. I can do this. And, you know, I'm already doing it. I just didn't realize it. So balancing the qualitative and the quantitative, even though sometimes the qualitative piece is more of a burden on the program folks.
Thank you. So, kind of related to what you were just talking about, and as we've discussed throughout the convening today, we've heard about the importance of partnering with individuals and organizations in your community, and you all have touched on different folks that you're working with. And so I'm curious if we can hear a little bit more about who are the most, the key partners you're working with, and who do you wish was a part of the work you're doing, who could help either bring in data that you don't have access to right now, who could help implement these data-informed solutions. Maybe Carla, we could start with you.
Sure. Yeah, I think, from like a practitioner kind of viewpoint, like a Medicaid practitioner viewpoint, I so thoroughly enjoy working with the managed care companies because I think that you get to leverage a lot of resources that they have, and then they like to compete with each other, so you get to leverage that as well. So it's kind of saying, well, you say you can do all this stuff, so show me, and then they get really excited and like, look at this program, look at that program, But one of the things that I've learned by being here at Urban is the value of community advisory boards. So I got an opportunity to listen and to participate in a community advisory board that was sponsored by some work that RWJF funded. And just hearing from people who actually receive the services that you're trying to put together, it's like they're able to articulate the unintended consequences of your decisions. And I think that that is the partnership that I want to build out in a more robust and sustainable way, because I think that it makes the policies a lot stronger. And it also, it ensures that you have buy-in for those new programs, because they're going to co-own it with you in a way that you just can't replicate by yourself.
As far as the center in a workforce aspect, a workforce capacity, we have a lot of different connections within the community to primary care centers. The center actually houses an FQHC, which has a residency program. So reaching out to them, just kind of seeing what the community has as far as their as their perspective of what's needed in the workforce in the rural area.
I think one of the greatest challenges that the research work group at the Partners for Rural Transformation is challenged by is the fact that we're in community across the nation and the territories. We have the opportunity to hear directly from people that are impacted by stack financing deals and health facilities that are funded and what it means long term. And yet the staff time and resources to routinely capture that over a 10-year period to show what happens in that community over an extended period of time, to visit and talk with the folks that are impacted by the facilities or the services or the loan, to show, did that, what other than just the single point of service happened? And it's difficult and it's expensive, and when there's so many needs, it's hard to prioritize the time and effort to capture that information, and yet that is where our impact lives and helps us understand what's going to change the face of this community 10 years from now. What helped families have healthier lives, which led to improved education, opportunity to improved livelihood, opportunity, all because we know it's all connected, it's all systems. But it's difficult to prioritize the time and the resources on that data capture over direct service provision, and yet we need both. And, there's never enough resources to meet all of the needs. So how do we balance that?
Thank you. So we have quite a few questions that have come in from our audience, and so I think we can turn over to some of those questions so we have time to get through a number of them. Also, as a reminder for those in the room, you can scan the QR codes on the tables to please enter any questions that you might have. So starting off, what advice do you have for rural stakeholders who are wondering about where to get data on their community health needs? What sources should they explore? How can they ensure they are collecting and using data appropriately? Sydney, would you like to start?
Sure. So I think the usual suspects are a great place to start. So census data, looking at CDC data, all of those things. But I also think leveraging some of the local data from maybe local health departments, or if you're interested in substance use disorder, maybe leveraging some of that from treatment facilities. People in your communities are willing to share data. How granular it gets is, it depends. But I think looking to your community for what people are tracking, and I think also paying attention to what things are missing, so that if there's a gap, that there's a need to be collecting those sorts of data.
Thank you. Do either of you want to add anything on this one?
I would be happy to share that through the Urban Institute's website, and I believe in the information provided after this event, the Partners for Rural Transformation in Urban have a guidebook that they've put out to help rural stakeholders identify some of those sources. And if you are comfortable with technology and a smartphone or an iPad or a computer, there's hot links in there that will take you to some of the websites that have readily available maps, information, data. It's just designed to kind of, as best as all of the smart minds that were in the room, I'm not including myself in that, but could pull everything together and say, okay, start here. And then definitely, as has been said, get out in community and talk to your community. It's pull the numbers, pull the data that's out there, but then go talk to people and ask, what's going on. Pull folks together for coffee. Listen. And make sure that you are talking to folks that you may not have met before, or you may not do coffee with on a regular basis, so that you're getting a very comprehensive view of all corners of your community.
Okay, I'll move on to another one, and you all can just answer as you feel inclined to. If you don't feel like it's something you feel interested in speaking to, that's totally fine. So many small rural communities may not want state or national groups without local knowledge to be prescriptive to them with solutions about what they think they should do. It's important to meet rural communities where they are, respect them, and ask them what may help them and what is needed. So do you have any examples about what is being done to address this problem in any of the work that you're doing?
So I could just highlight, the first example that I provided. One of the things that was really important was the managed care companies needed to almost like recruit provider groups for this performance improvement project. And a part of that recruitment was sitting down, as you've heard repeatedly, and saying, what are your pain points? And it was also important to take a step back and say, I am here in service to you. I'm not here to try to fix the problems that I think I see. I'm here just as a resource to you because you have the solutions to both identify the problem as you see it, and then to tell me how you would like to address it. And so I think that there is like a humbling that has to happen where you have to be comfortable enough in yourself to say, I don't mind playing second stream if we are able to help you accomplish a larger goal.
One of the things that I think is an advantage of the center, we have a community health worker program. And we've trained the community health workers not only to go out and address the people who are most vulnerable, but they're also researchers. So they're out collecting data, and we take that data and we meet with them and get their feedback on what are the ways that we can address some of the health needs in the community. So we've actually trained people to be researchers out in the field, and that has been really fruitful for that program.
I think it begins with building some rapport, if not trust, with those that you are trying to serve. And I like the word serve. My personal experience facilitating community meetings, I've had one beer can thrown at me. I've had people say, why should we believe you? It sounds too good to be true. Other people have said that. Why should I tell you what I think my community needs? I told the person that came before you. Why are you any different? Why should you be trusted? And those are all legitimate questions, especially in some of the areas in the South where we work. And it's like, well, I can't guarantee that anything's going to be different this time. But at Communities Unlimited, we call it community sustainability. That's our focus on community-led and driven interventions. And it is very much an approach of, we're here, we have resources, we have some experience, we have other partners that have different experience. Tell us what you believe your community needs, and bring all corners of your community to the table to share with us that what the common denominators are. And I think one little thing that I've learned from Martha Claire, she's the director of that program, is look for an immediate small win to build that rapport. What can you do? And just do something. Nick Mitchell-Bennett, CDCB, says that all the time. Just do something. And it's like, do something quickly that needs to be done. If it's painting stripes on a city street so that everybody doesn't park sideways anymore. I mean, whatever it is, something that's a win to build rapport that shows you listened to what they thought was important, and then work in partnership with that community to take on perhaps some challenges that are a little more complex and that might take a little bit longer to resolve.
Thank you. What data do you wish you had for the communities you work with that isn't easily available or maybe isn't available at all? And how could filling that data gap advance rural health equity?
I often think about those conversations that don't happen because that trust is not there. And I think it is, as you've just stated, it's just that trust, it takes a really long time to build, but it can be destroyed very quickly. And so it ends up to the data that I wish I had would be the data that, or the information made available when there are trusted relationships. Because I think that a lot of times the solutions are there if you can convince people that, one, you're there for the long haul, that you're not there for a personal glorification, and that you are there in service. And so when they choose, if they choose to open up to you and really reveal their most vulnerable versions of themselves, that ends up being the gold nuggets that you guys can co-program around to address those kind of root cause issues. So it ends up being, you know, those data points that never make it into the data set.
I think from the workforce standpoint, it's not so much what data is needed, it's kind of the collection of data that needs a revamp. So when we're accessing different licensure boards, so medical, dental, nursing are the big three that we focus on. Data is collected in different ways across all of the different licensure boards. So you might get one piece of information in the medical licensure board that you won't get in the nursing. For instance, registered nurses, there's only a collection of home address, whereas in the medical licensure, it's work address. So we're kind of comparing apples and oranges when we're looking at that county level data. So just kind of standardization across the board of those different licensure boards would be extremely helpful in telling the true story of those workforces.
What data is missing? What do we need? All of it. When you're talking about sub-rural, I mean, when you're looking at very small, rural, isolated communities, census, ACS, BLS, everything that's out there is good, and we need more that reflects the specific community that is asking for the intervention, the specific population of service, because it can look different from what the collective data set might show. For example, for a county level where you have 7 small rural communities in one county. I don't know that there's an easy answer to that because it does require trust. You know, the one thing we're pretty adamant about is that a community's data belongs to the community. That is theirs. A person's data is theirs. If they choose to share it, then we have an agreement about what could be done with it and what cannot be done with it. That's very important in this day and time. And even then, just earning the trust for folks to share income, you know, to share what their health challenges are, to share what their assets are. Do they have any savings? What's their debt to income ratio? I mean, you can. I wouldn't just tell a stranger on the street the answers to those questions. For myself, none of us would. And yet we're asking them to give us this so, you know, that we can work. And it's needed and it's necessary. But again, it's part of that conversation and building that rapport. And then I believe there needs to be very well thought out governance over the data and how it's used, and, you know, tools that support all of us in this field for how we can collect it, share it, and respect the privacy and the ownership of the original source.
Thank you. So we have just a few minutes left, so maybe this can be the final question to wrap up on, but would you each give us just maybe a brief, exciting or unique example of how you're using data in your work? We've talked about challenges, and it would be, I think, nice to also honor all of the innovations you're doing, and so maybe just a brief explanation.
Yeah, I think for us with the workforce data, getting that extra funding in student loan repayment has been huge for us. There's been several dozen people who have received that in the last year. We received funding last year, so since then we've had several dozen people receive that funding, and our research with our current student loan repayment program through the Kentucky Office of Rural Health suggests 80–90% of people who receive that funding end up staying in rural. So we hope to have these new fundees be able to stay and work in rural as well.
So for me, I serve on the Georgia Maternal Mortality Review Committee, and the work of that committee, we review every maternal death in the state. And in August of this year, I was able to give It was the first to my knowledge, but able to give the report to Medicaid about all of the maternal deaths from 2018 through, I think, 2020. And to break that down by payer, by cause of death, by region in the state, so that we understood kind of what regions really had the greatest burden. Because in most places, as you were just describing, rural gets kind of absorbed into these big numbers because you've got more people in urban spaces, and so that rural story gets lost. So what we were able to do with the presentation was showcase what does maternal mortality look like in rural spaces across the state. And the next set of conversations are around how do we program to address the needs that are specific to those regions. So I'm really excited about the opportunity to do that targeted work and drive down this maternal mortality crisis that we find ourselves in.
I have two. I get really excited when the staff and our organization, Communities Unlimited, come to me and say, you told me about that map thing on my phone where I could use it and I could enter information that I learned when I'm out in the community, and yes, I've forgotten, would you show me again? Because I'm like, I'm happy to. For me, that's like, a new research partner, a new data collection partner. That's like, I'm out in this community and I'm willing to take time to learn a new tool. None of us have time for that, but they take the time to learn to share information with me. So that's, for me, I get excited when folks understand the value of that. And then honestly, the Partners for Rural Transformation. I've seen nonprofit CDFIs collaborate in a way, and I have the gray hair, I've been around a long time, that I've never seen before. I was not involved in the original forming of the partnership or anything. I came into a work group much later in the organizational structure. But, we've heard about how you can't, you want to be sure with your partners you don't end up accidentally competing for funding. Well, the partners could all theoretically compete for this, sometimes for the same type of funding. They're all CDFIs. They're all going after capital. They could all be competitors. But they're choosing to not think of it that way and instead view each other as partners. How can we collaborate to leverage even more and do more? And they're sharing data that exists within the organizations with each other, protecting confidentiality. Bless Emily's heart, she spent a long time defining that governance and the security for borrowers and everything. But they're pushing through and they're finding a way to share and learn. What's Hope got cooking with, healthy foods and fresh markets and grocery stores, and have they found the solution that's going to solve it for, very rural communities? I hope so. I can't wait to learn about it. But it's just that sharing of data. And it can work. It takes committed time and effort and folks willing to define the parameters. But, I think there is an example of a partnership that, is leveraging that data and that information to have even greater impact. So I would just encourage you to reach out to your partners and just explore it. They may say no at first. Ask again. What could we do to make this work? Because the more data and information we have, the more effective we can be at deploying the resources.
Thank you all so much for traveling here to be with us today and sharing your experiences and expertise. We really appreciate your time. Thank you all for listening. I will now pass it off to my colleague, Corianne Scally, to wrap up our event today. Thank you.
Hi, everyone. Thank you so much for joining us today. We had several goals for this event. We were hoping first to highlight rural health disparities and make the case for more innovation and investment to meet rural health needs. We wanted to elevate some promising practices employed by those on the ground who continue to adapt their systems and services to meet the needs of diverse rural populations that they serve. And as a research organization who believes in the power of data to point to problems to tackle, but also to solutions that have real impacts on people's lives, we wanted to offer some ideas around mobilizing data to meet rural health needs. But our overarching goal is to inspire action, to ensure that all rural people and communities have the opportunity to live their healthiest lives. So whether you are new to thinking about rural health or well-seasoned in this field, we hope that you're leaving with some solid ideas on what you might try next to help advance rural health equity. We will continue to engage with partners and lead on research to address structural inequities that perpetuate health disparities in urban and rural places. You can explore our website for recent work on rural people and places, from food access and housing supports to education and human services to climate migration. Our researchers are highlighting rural needs and pointing to solutions. And in 2024, look for new work connecting rural water and wastewater infrastructure to economic development, highlighting promising models for expanding financial inclusion in rural places, and improving data on rural disability to support community living. We really look forward to continuing this work in partnership with many of you. So on behalf of ourselves and our co-host, the Partners for Rural Transformation, thank you so much for joining us today.